Hello guys, today we are going to discuss about anticoagulants. So what are meant by anticoagulants? Means which prevent the coagulation. So first we'll quickly go on see the classification of these. Anticoagulants are classified as parenteral anticoagulants and oral anticoagulants. In parenteral anticoagulants there are indirect thrombin inhibitors and direct thrombin inhibitors. Indirect thrombin inhibitors are heparin, unfractionated heparin and low molecular weight heparins. Low molecular weight heparins are again enoxaparin, rivaparin, nadroparin, datiparin, parnaparin, ardiparin, fondaparinux and donaparoid. And direct thrombin inhibitors are bivalirudin, argatroban. Okay. Oral anticoagulants are vitamin K antagonists. They are bishydroxycoumarin, which we call it as dicumarol, warfarin sodium, acinocoumaril, we will call it as nicomalin, and ethyl biscoma acetate. And direct factor 10A inhibitors are rivaroxaban, apixaban. Oral direct thrombin inhibitors are dabigatran, etixylate. Okay. So first, before we discuss about this anticoagulants, first we have to learn about coagulation cascade, because it is very important to understand this mechanism of action of this anticoagulants. So let's discuss it. Coagulation cascade, it has intrinsic system and extrinsic system. Intrinsic system, it is activated by contact, and the factor 12A will get activated, and 10 by this 12A factor, 11th factor will get activated into 11A by means of high molecular weight kininogen, and this 11A will act upon 9A, and this 9A will get activated into 9th factor will get activated into 9A, and this 9A will act upon 10, and it activates this 10th factor into 10A. Okay. And this 10A will act upon prothrombin, and it converts the prothrombin into active thrombin in the presence of plasma phospholipid, plasma phospholipids. So this thrombin this thrombin will act upon the fibrinogen, and it will convert the fibrinogen into fibrin. This fibrin which is soluble on again action upon the thrombin, and 13A factor we will get fibrin which is insoluble. Okay. In the extrinsic system, what we are getting, this 7th factor will be getting converting into 7A due to the exposure of the collagen due to the tissue damage. Okay. After this, what will happen, this 12th factor will get converted into 12A, 11th will get converted into 11A, and with the help of killicarin and tissue factor calcium ions, this 10th factor will get converted into 10A, and this is this 10A which is a common point, right, for both the pathways, and this 10A will act upon the prothrombin, and prothrombin will be getting converting into the thrombin. Okay. And as usual, this thrombin will act upon the fibrinogen, and we will get fibrin. Okay. Okay guys, did you understand this coagulation cascade? And this H is heparin. Heparin will inactivate all the factors which are involved in the common pathway, and it won't affect the 7A factor which is involved in the extrinsic system. Okay. Let's see next. So heparin chemistry and occurrence. It is a non-uniform mixture of mucopolysaccharide. Okay. Straight chain mucopolysaccharides with weight of 10,000 to 20,000. It contains D-glucosamine L-edoronic acid and D-glucosamine D-glucuronic acid. Heparin carries electronegative charges. It is the strongest organic acid which is present in our body. Mast cells, their degranulation will help in the release of heparin. Okay. mast cells will be present in the tissues, okay, and this heparin will be present in almost all the tissues which contains the mast cells. And richest source of heparin are lung, liver and intestinal mucosa, okay. What are the actions? Actions are anticoagulant action. It acts directly by uh, inactivating thrombin by activating plasma antithrombin 3, okay. This heparin antithrombin 3 complex will binds to clotting factors of common pathway and inactivate them. So factor 7A, which is involved in the extrinsic pathway, it is not inhibited by this heparin, okay. And at low concentration, heparin prolongs the active plasmin thromboplastin, okay, and prolongation which is seen in the prothrombin time, okay, thromboplastin time, okay. Higher concentration prolongs both the active plasmin thromboplastin time and prothrombin time. Antithrombin 3, which is a substrate of protease clotting factors, so it will bind to the protease and to form the stable complex. In absence of the heparin, the interaction between the antithrombin 3 and protease will be very slow. So this heparin is enhancing the its action in various ways, okay. So for to prevention of the clotting, this antithrombin 3 should binds to this protease, okay. Then only this clotting factors will get inhibited, okay. Otherwise the interaction will be very slow between these antithrombin 3 and protease, okay. So let's get continue. Long molecule heparin, it provides a scaffolding, okay. Here we will see this all this mechanism what I had written there. This is long molecule heparin or unfractionated heparin. This long molecule heparin, it will provide some large scaffolding so that antithrombin 3 it can binds with the 10A by undergoing some conformational change and exposing its interactive site. And it can also bind to the thrombin due to this large scaffolding, and it will also inhibit this thrombin along with the 10A, okay. This is while coming to that while coming to low molecular heparin, low molecular weight heparin, it has pentasaccharide sequence which is present, and it is low molecular weight and it is short. It provides low scaffolding. Then antithrombin 3 can only binds with the 10A by exposing its interactive site, okay. It won't inhibit the thrombin in low molecular weight heparin. So if higher dose of heparin, we will see the reduction in the antithrombin 3 levels. Why? Because compensative mechanism, feedback inhibition, and we will see the reduction in the antithrombin 3 levels, okay. Sudden stoppage during the treatment will produce rebound coagulability for few days, okay. This is understand. Okay, do you understand this concept? Okay, hope you understand, guys, and we'll go further. Right. So heparin in higher doses inhibit platelet aggregation and prolongs the bleeding time, okay. Heparin causes an inhibition of calcium mobilization. If there is no calcium, which is fourth factor of coagulation, then there will be no clotting. So heparin prevents the clotting. It is specific to thrombin and collagen, okay. Only this specific action is restricted to thrombin and collagen. Stimulant and dose dependent reduction in the collagen mediated coagulation. So lipemia clearance, it clears the postprandial lipemia by increasing the lipoprotein lipase levels from the tissues. This lipoprotein lipase, by the word only we will understand that lipase, it is breaking down the lipids. So it breaks the triglycerides which are present in the chylomicrons, and release of free fatty acids will be occurring into the circulation. Okay, what are the pharmacokinetics? Heparin is a highly ionizable. If we give orally, it is easily excretable. So we should give IV. If we give IV, it is action is instantaneous. So we should be giving on continuously. We should give. So we'll give subcutaneous injection, which is preferable, with an angle of 45 degrees. Okay, action will develop over the 60 minutes. Okay, it does not cross the blood-brain barrier. It is safer during the pregnancy because it won't cross the placenta also. So child won't get bleeding disorders. Okay, so it is metabolized in the liver and excreted in the urine. These mast cells will secrete this heparin. If Ig antibodies will get and bind to the Fc sites, Fc binding sites, then heparin will be released. And not only that, sometimes heparin will be released but due to the degranulation of the mast cells, and this heparin will be actively degraded by the tissue macrophages. If it not degraded, normal homeostasis can be maintained, and as intraorganal bleeding, everything will occur. Okay, if we give IV, we should be giving heparin in the form of sodium heparin or calcium heparin. We should give it by continuous infusion because IV means rapid action is seen. So we'll give deep subcutaneous or intermittent IV injection. Okay, before any surgeries, because in surgeries prolonged immobilization which is seen, which will lead to the clot formation. Okay, so we'll give during the surgeries, and we'll continue till the patient which is discharged. And T half will be 60 minutes up to if we give less than 100 units per kg, T half of the heparin is 60 minutes. It will act up to 60 minutes. If we increase the dose of heparin, the T half also increases. Okay, T half prolongs in the cirrhotics. Okay, if there is liver damage, it is metabolized in the liver, right? So there is liver damage, liver cirrhosis there. So how it will be excreted, how it is metabolized and excreted? So T half, it will show more action in the cirrhotics. Okay, who suffer with cirrhosis. So T half decreases in the pulmonary embolism. Unfractionated heparin is safer in renal failure patients. Okay, because excretion is through kidneys only, but this is safer in renal failure patients than low molecular heparin, because this T half is 1 hour, right? In low molecular heparin, T half will be prolonged. Okay, dosage is IV, we should give 5000 to 10,000 units bolus. In children, we should give 50 to 100 units, followed by continuous infusion, 750 to 1000 units per hour. In adults only, this one continuous infusion one. Alternatively, we should give anti 10th A factor inhibitor. Okay, anti 10A. Okay, which is we will also call as a 10th A inhibitor, right? And we should give protamine sulfate, okay, for this action. Subcutaneously, we should give insulin 5000 units up to 8 to 12 hours. Okay, okay guys, and let's learn about adverse drug effects. Okay, adverse drug effects are if we give overdose of heparin, it will inhibit these clotting factors, and we will see prolonged bleeding. And proper monitoring, if we give proper monitoring also, overbleeding may occur in 1 to 3% of patients. Sometimes heparin will cause thrombocytopenia and decrease in the platelet count will occur, and platelet aggregation will be occurring, and in high doses of heparin. Okay, transient and reversible alopecia, which is seen, but it is somewhat rare. Okay, serum transaminase levels will be increasing. Osteoporosis occurs on long term use and with high doses. Okay, hypersensitivity reactions which are rare, if at all there, they will be, patients will present with urticaria, rigor, fever, and anaphylactic shock. And patients with allergic diathesis are more liable, because what is a diathesis? Diathesis means they are already suffering with allergy and they are given overdose of heparin, then they will patients will present with allergic diathesis. So we should be very careful. We should understand the history of the patient very clearly, and we should ask for allergic history with heparin. Okay, what are the contraindications? There may be bleeding disorders, history of the heparin induced thrombocytopenia. If there are bleeding disorders and heparin induced thrombocytopenia, we should not give heparin. It will aggravate the symptoms, and severe hypertension will occur, and cerebral hemorrhage will occur, which is very serious complication. Okay, if we won't treat this cerebral hemorrhage, okay, then death of the patient will occur. And in pregnancy, if we give high doses, abortions will occur, piles, gastrointestinal ulcers will occur, and peptic ulcers, these all will occur. Okay, subacute bacterial endocarditis and large malignancies, if we should not give this heparin. Okay. Okay, so we should not give. If we give, this bleeding will prolong. Okay, in the central necrosed area, in the tumor conditions, this bleeding will prolong in the central necrosed area of the tumor. Okay, tuberculosis patients, we should not give heparin, because there is a risk of increased bleeding in the sputum. Okay, ocular and neurosurgeries and lumbar punctures, we should not give heparin, because as there is excess loss of bleeding will occur. Okay, and chronic alcoholic cirrhosis, renal failures, we should not give, because THAF will get prolonged, and heparin induced bleeding will occur. Aspirin will cause bleeding, right? And peptic ulcers also it will cause, so we should not give. And along with the antiplatelet drugs, the patient is taking aspirin, he should not take this heparin. Okay, and he should, if he is using another antiplatelet drugs, we should not give this heparin. So we should think before we are giving the heparin. Another important one we should remember, we should not give heparin intramuscularly, because it may cause hematomas. Okay, be careful, cautious while giving heparin. Okay, we should give subcutaneously 5,000 units to 10,000 units. It is better. Okay. Thank you guys. Thank you for listening to me carefully and patiently, and we'll continue with the new chapter afterwards. And thank you guys. Thank you so much. Hope you like this video.